Just takes a second? Okay. So my name is Brian Stegman. I'm one of the interventional cardiologists at the Central Care Heart and Vascular Institute in St. Cloud, Minnesota. So thank you for letting me come and present my case. So there's a lot of clinical history here, and I apologize for all this, but you kind of need to know it to understand my state of mind going into this. So 67-year-old guy, about a year before I met him, was a pretty healthy guy, no major medical problems. Had a contained rupture of a AAA. Underwent emergent open repair with aortobifemoral grafting. This was complicated by colonic perforation requiring resection and colostomy, splenic capsular tear requiring splenectomy. They were unable to close his abdominal incision, so he was left to heal by a secondary intention, and he also had a non-ST. During this time, had a cath from his right radial at that time, demonstrating a CTO of his right and a severe med-LAD stenosis. So he presented to our institution, to one of my colleagues, complaining of increasing dyspnea and exertion. He talked to surgery. They said, we're just going to let this heal. So the plan was to proceed to LAD PCI. He came in for angiography, and exam at that time demonstrated occlusion of his bilateral radial arteries. He had a prior CT scan that they looked at, showing that the graft to the left CFA was anastomosed and the distal CFA, and the proximal SFA was occluded. On the right, he did have a patent proximal SFA profundus, so the plan was ultrasound access of the distal right CFA. So this is his coronary angiogram. So he has some kind of borderline stenosis in the first OM, has that severe ostial stenosis and this severe LAD stenosis. Not sure how well this projects, but it's a little grainy, but is pretty severely calcified, especially in the mid-LAD and the ostial LAD. And this is his right, chronically occluded, but with good collaterals. So given his new ostial LAD disease that was extending into the main, the decision was to send the patient for bypass surgery, or at least evaluation for bypass surgery. Unfortunately, he had the sheath removed under manual compression, had severe right lower extremity pain, exam demonstrated an occlusion of his aorta bifem graft. He underwent emergent surgical embolectomy and PTH of his popliteal artery for a clot. Actually did exceedingly well after that. Was medically managed for his coronary disease for some time. Actually underwent attempted closure of his abdomen and reanastomosis of his colon, which was complicated by a perforated anastomosis and extensive bowel resection, and the guy was on TPN. So he came to see me after he had been on multiple antianginals and was kind of not doing too well. Couldn't walk to his mailbox without getting really short of breath, had an EF of 45% with an inferior wall motion abnormality. So when I saw him, I was wondering about, is he even going to absorb P2Y12? What's his access? Do I need to do atherectomy? There was a lot of calcification in the LAD. And do I need support? So I put him on prasugrel for a week and did a P2Y12 inhibitor panel, and it looked like it was good to go. I ultrasounded his radials, and he had bilateral radial occlusion, but on the right it was occluded all the way to the brachial. On the left it was kind of a fairly short segment occlusion. So decided I would go left radial just halfway up the arm. I did feel like we needed atherectomy, and because of that I did feel like, and because of all his other history and my general nervousness going into this, I felt like I needed support. So did a CT scan of his subclavians, and this is a recon of his left axillary, and you can see the measurements all measure pretty big, range from 6 millimeters in the mid-subclavian out to 8.5 in his axillary, which we often see. So I decided at that time, after talking to him for a while and kind of trying to dissuade him a little bit, that we'll go ahead and try this from the left radial. Obtained ultrasound-guided left radial access because I was ways up the arm. And through that, put a pigtail, did an angiogram of the left axillary. So this is kind of, we do a lot of axillary access in our center, and this is kind of our usual protocol. We mark it under fluoroscopic guidance, and then under ultrasound guidance, get access. This is accessing trying to avoid the branches, accessing the axillary artery, and perform pre-closure, place the Impella sheath, and this is the Impella placement. So I don't know how many, you guys do a lot of axillary Impellas, but The sheath always kinks, and it kinks a lot, and you kind of have to do this push-pull technique to get the Impella to cross through the sheath, but it generally goes. This is our angiogram to start. So you can see there was a little bit of ostial left main disease that Iveston is huge and is actually just kind of how it takes off, and there's really no disease there. And there's pretty severe stenosis in the mid-LAD, which looks like it's progressed from previously and has that severe osteostenosis. So I did decide to fix that circ, put one stent there, performed orbital atherectomy, about 4 or 5 passes at low speed in the mid-LAD, and then 2 passes at low and 2 passes at high in the ostial LAD. This was unfortunately the only picture that they took of it, so you'll have to believe me. But that all went pretty well. I was actually very happy I had the Impella, though, because on about my 3rd pass of CSI, he kind of lost all pulsatility in his, on the Impella waveform and on our pressure waveform. I honestly don't exactly know why. I looked through everything. There was no dissection. We had good flow, but came back after about 3 minutes. Ballooned his LAD, stented his LAD, had a little bit of distal edge dissection there, and put another stent there. Stented the LAD into main there, and then post-dilated the ostial LAD and the mid-LAD, and then post-dilated with a 6.0 balloon in the left main, and opened the side branch of the circumflex. And this is our final angiogram. I left that ostial diagonal stenosis. Felt like that was reasonably medically managed. So this is our Impella removal. Coming out again through the kinks. So we generally put an occlusion balloon distally when we're closing, just to make sure that we don't have a whole lot of, we obtain good hemostasis. So this is the picture from that. And this is our final post.
You said you pre-closed?
Yeah, yeah.
Just one?
Two.
Two.
Yeah. Kind of make that decision based on how big this was a big artery. So, and this is what our sheath removal site looked like. And follow-up, I saw him at about a month. His shortness of breath had significantly improved. He's doing a lot better. He remains stable on the TPN, and I'm going to medically manage the CTO unless otherwise needed.
So, good case. The only thing I do different is I use floor road maps, so DSA for axillary puncture. So,
Okay.
you know, even if they're breathing, it doesn't move much, and you can just visualize where you want to go. And then I do a DSA picture at the end because you can have subtle mushroom cloud or bleeding that regular angiography doesn't detect. So for the completion angio, let's do
DSA.
Visual obstruction.
Yeah.
So when we do, great point. When we do for the TAVRs, we always do DSA angiography. I still get ultrasound guided access, but for the completion angiography, we do DSA. In this particular lab, I had a small eye with no DSA, so.
The ultrasound is
the
probably
pictures.
adequate. I mean, you could do it all the time for pacemakers, and it's just, you can see everything you're going after and avoid
Yep.
the lung. So I think the DSA definitely works, but three-dimensionally, you can see it better.
I feel like I can see the branches better, too. I have some idea where I'm actually accessing the artery to some degree, but.
I think that was a great case showing how drip planning actually is helpful. You do the CTA, see the size of the vessel. I mean, during that episode of no reflow, if you didn't have your Impella, this could be a disaster.
It would have been, yes.
And you would have presented.
Yes, exactly. That's true.
Thing, I mean, if you have low EF patient, multi-vessel disease, you want a rota, you want a atherectomy, you always should think of no reflow and having support, as difficult as it could be. I think is the way to go. And you could get lucky one time or 2 times, but it's going to catch you.
Good planning. What size would you cut off? Would have been your cutoff for that Impella?
So probably about 5. Yeah, 5.5. That's what we've generally been using. If there's a lima, CP. Yeah. When there's a lima there, I like at least a millimeter or 1.5 millimeters or 2 millimeters greater than the sheath size. But,
Thank you.
all right, thank you.